Hello, everybody. Welcome to our webinar. Today's topic is going to be transforaminal endoscopic discectomy. But endoscopic surgery is a growing field, so it's not only discectomy, but we can address many more pathologies by endoscopic surgery. And it's not only lumbar location, but it's another regions like cervical and thoracic that can be addressed. And it's not only transforaminal access, but more other approaches that we can take. Transforaminal approach has its advantages. It's less invasive. You don't need to open flavum ligament. You don't frequently even need to enter epidural space. There is little or no damage to paraspinal muscles. And it's easy to redo by any approach. You can choose transforaminal, interlaminar, or whatever you want with minimal fibrosis. You can deal with foraminal and extraforaminal pathology, which is not easy even by transforaminal, but almost impossible by other approaches. And the anatomy may be more familiar for me as a pain actor. The major disadvantage is that you are just unable to reach certain pathologies, and you have to choose another approach for them. Radicular pain is quite prevalent situation, and the most frequent cause, especially in younger patients, is the herniation. There are some risk factors like male sex, obesity, history of smoking, depression, and some occupational factors. Nowadays, mainly sitting. And radiculopathy is mainly clinical diagnosis. It's diagnosed as a pain of typical neuropathic character in dermatomal distribution with some correlating pathology. There may or may not be motor weakness or numbness, or weakness or numbness could be the only symptom the patient has. Electrophysiology and reflexes may be frequently confusing, and they are not necessary for diagnosing of radicular pain or radiculopathy. What may be very useful is some interventional workup. We frequently perform transforaminal, or we almost always perform transforaminal steroid injection, diagnostic and mainly therapeutic. From time to time, we perform selective nerve root block just to refine the level of pathology. And more frequently, we perform selective dorsal annulus block, again, to localize the pathology in case of discogenic or axial pain. Quite important is from time to time perform prognostic blocks to exclude other possible sources of pain, because asymptomatic finding on MRI is quite frequent, and so it's easy to miss some differential diagnosis of pain which may look like radicular, and patient has some finding on MRI, but it's something else. So it's always a good idea, if you're in doubt, to exclude other possible causes. So indication for endoscopic surgery is usually radicular syndrome or spinal claudications and some surgically treatable pathology on MRI. Important is really correlation of pain and clinical findings with imaging. We operate quite early sometimes if there is severe weakness, or urgently if there is Cauda syndrome. But usually it's after failure of conservative treatment in length of 6 to 12 weeks, plus some transforaminal steroid injection we perform before procedure. In some cases, we don't wait so long, especially in elderly patients, and sometimes even in very active patients, which want to get back to work or common activities very early. And really, if you are in doubt, you should exclude any other possible causes of pain. Nowadays, another growing field for endoscopic surgery, discogenic pain, but it's different chapter. And from practical point of view, classification of herniation is important from the point of mainly localization, migration, and also propagation, because it's important for choosing proper trajectory to pathology. Regarding treatment strategy, I would prefer some kind of pragmatic approach that we relieve major symptoms of specific patient, do the procedure as little as possible, and leave something to physiotherapist and to the patient, because I think there is no preventive surgery in spinal region. The endoscopic procedure has basically two parts. The first part is establishing the way to pathology, so we need to get to pathology. And the second part is the actual endoscopy, where we treat the actual pathology. If we are accessing spinal canal, we should establish the most direct way to pathology. Sometimes it's not possible, but it helps a lot with surgery to have the suspected pathology just in front of your endoscope instead of over the corner. By accessing the spinal canal, we can partially treat the pathology by doing foraminotomy or recess decompression and so on. Access to spinal canal is possible source of some complications as well. It happens very rarely, but it could happen. Damage to nerve root, bleeding, damage to end plate, and so on and so on. And there are some factors impeding transforaminal access, which I will discuss later. Important for your surgery, as I said, is to get as close to the pathology as possible. And for that, we need to plan our trajectory. I will skip this text and I will go straight to pictures, which may help to understand better. This first picture is a steep or paramedial approach, which can be used for extraforaminal pathology, but I use it quite infrequently because it's even for extraforaminal pathology. It's sometimes not easy to get because there is exiting nerve root just in your way to possible extraforaminal hernia. So sometimes even for extraforaminal pathology, you need to choose more shallow access or more shallow trajectory. This is classical posterolateral approach, which you will achieve if you plot distance from ventral edge of vertebra to skin, and plot it laterally on the patient. And from here is your entry point, and you will get into the spinal canal approximately under 45 degrees angle. It can be used for foraminal, even extraforaminal or paramedial pathology or hernia. This is more shallow approach, more lateral approach from level of spinal process in lateral projection on X-ray. If you plot it on patient, then it's your starting point, and you will get there on the shallower angle. And the more shallow is your angle, the more medially you can get. So this angle is for preforaminal or even medial hernias. And the most shallow and the far lateral approach is at the level the same approach as before, but at the level of facet pillar, and you can reach almost to the other side of the spinal canal. It depends, of course, on how big facet joint is and other aspects, but sometimes you can. Another important thing in planning your trajectory is craniocaudal position of skin entry point, which depends mainly on how far is hernia propagated or if it's in the disc level. The more caudally is hernia, the more cranially you will start to get this trajectory directly to the hernia. And if the hernia is cranially migrated, you will start from the caudal part and go up. You can help yourself with some kind of flexible graspers and things like that, but it's always better to have the hernia in front of your endoscope. Problem comes sometimes in L5S1 level, especially with cranially migrated hernia for obvious reason. The iliac crest is not allowing you to go this way from lateral. The same in lateral projection. You can see exiting nerve root and position of working sleeve regarding to exiting nerve root. The original strategy how to get into pathology was inside out technique. That you insert needle to Camden triangle, you go intradiscally, you perform discography, then intradiscal decompression, some annulotomy, or yes or not, and then epidural decompression, which sometimes is not easy because you are unable to get there. I think, and I mean, many people would disagree. I think it's obsolete now, and good way how to get there is outside in or outside out technique, which is based on docking the needle on SAP and coming to SAP and then transforaminally to slip over the SAP. You can or you don't need to perform foraminotomy, and you don't need to perform intradiscal decompression, and you don't need to enter the disc because sometimes it's necessary, but it damages the disc, so it's better to avoid it if possible. There are some anatomical obstacles that prevent you from entering the epidurals or the spinal canal, and most important are iliac crest, position of exiting nerve root, foraminal dimension, hernia position and migration, and sometimes even BMI of the patient. The higher is iliac crest or L5S1 level, the harder is to get there, of course. And sometimes you need foraminoplasty, or you need to choose a different approach if the iliac crest is higher, or if the hernia is cranially migrated. Another thing is position of exiting root in the foramen. This is ideal position of exiting nerve root, but it could be like that, and even like that. So in those cases, it's hard to get into the foramen without damaging exiting nerve root, and you need to perform foraminotomy or choose another approach. The same applies for small foramens. This situation happens usually in lower lumbar regions, and sometimes you need to get a foraminotomy or choose another approach. Craniocaudal migration, if it's very migrated hernia, again, sometimes you need to go interlaminar because you are unable to reach it through the foramen, even if you choose very steep approach. And it applies mainly for cranially migrated hernia in L5S1 level. That usually it's really a problem. BMI of patient. recently we meet more and more patients which are very big, and sometimes we are reaching the length of our instrument. Working sleeve for transforaminal endoscope has around 17 centimeters. So if you have trajectory of 20 centimeters from the skin, you may not be able to reach this hernia, and you should go more medially, but you cannot, because there is facet joint. So in this case, I've chosen interlaminar approach. Interpedicular distance. Bigger interpedicular distance is good for interlaminar surgery and bad for transforaminal surgery, because you are unable to reach or enough medially with your endoscope from lateral, but the interlaminar window is bigger. So for interlaminar approach, it's advantages. For transforaminal, disadvantages. So we have some strategies how to deal with these problems. Mainly, we take foraminotomy or interlaminar approach, but there are more other approaches that we can take to deal with such problems. So if you are getting to spinal canal, the first thing you should establish the proper trajectory to paint it on the patient or to draw it on a patient, and then act accordingly. So incision puncture by needle, inserting guide wire dilation. It depends on system you use. We use some shitty needle and manual drills to get into the foramen, but there are systems that don't have it. And your target is dorsal aspect of the disc, and looking on the side of presumed pathology. If there is pathology at the disc level, it could be like that. If there is pathology, if there is caudally migrated hernia, it could be like that. But still, your pathology should be in front of you. When you are in place, your endoscopic procedure could begin. And first of all, you should identify some anatomical structures. You start with pedicle, SAP, and possibly flavum, because it's the most safe place to be, in the corner between pedicle and SAP. And then you go deeper and you identify end plates and then the disc. Then you decompress using graspers, radiofrequency probe, and it's usually enough for discectomy, but you can use Carisons, IC drill, and other instruments as well for more complex pathologies. At the end of the procedure, you can coagulate annulus, denervate synovertebral or basivertebral nerves, and then you can see epidural space, possibly, or you don't need to, traversing nerve root or dura, and sometimes exiting nerve root if you are decompressing foramen. But it's not really necessary. If you perform just hernia decompression, you can be on the posterior longitudinal ligament, so you don't need to see even epidural space or traversing nerve root. And it's good, it's fine. Here is some anatomy. Here is SAP, pedicle, disc space, end plate. This is caudal direction, cranial direction. This is left-sided anatomy. So this is the picture you see usually when you come in. And at the end of the procedure, you can see decompressed traversing nerve root. Again, SAP, ligamentum flavum here and disc here. But as I said, it's not necessary to see always traversing nerve root, and you don't see it very frequently. Your procedure is finished when you see pulsations of posterior longitudinal ligament or epidural space or dura. If there is enough free space, unrestricted movement of instruments in the area where the pathology was. And the disc level is not exceeding end plates dorsally, so disc is leveled with end plates. That's ideal situation. Here's example of surgery we performed. It could be a very easy procedure in 25 minutes. Patient leaving hospital 1 hour later, walking nicely without any problem. It looks nice, but what about evidence? There is quite a recent study comparing full endoscopic versus open discectomy for leg pain, for radicular leg pain. There were almost 700 patients enrolled. So it was non-inferiority study, and it showed that on the picture you can see that it's actually that endoscopic discectomy was actually superior to open procedure. On the top of that, 94% of endoscopic procedures were performed as day surgery, and only 6% in open group. There were no conversions to open after learning curve, and around 5% reherniations in both groups, so normal reherniation rate. Interestingly, there were only 2 complications, and it was just transient neurological deficit in endoscopic group, and 8 complications in open group, which included bleeding, thrombosis, and cerebral spinal fluid leaks. So it looks that endoscopic surgery is good for patients, but is pain physician good enough to perform endoscopic surgery? And it looks yes. We compared pain physician with neurosurgeon in our study, and it shows that that the results are exactly the same. It was 70 versus 70 patients, and the complication rate was very similar, with no differences between those 2 practitioners. So instead of conclusion, I would set 3 questions. If is spinal endoscopy a game changer in surgical treatment of herniation? If is spinal endoscopy becoming a new standard in treating patients with disc herniation? And if does spinal endoscopy belong to hands of pain doctors? I hope you are going to answer yes to all these questions after this presentation, but I leave it really to you. So thank you for your attention, and maybe see you next time. Thank you.